Go ahead. So once again, I'm Tom McCormack, Vice President of SSO. I'm going to read a quick mission statement about us for any new people joining on. So our goal is to bring together the surgery staff and medical students in order to broaden students' knowledge of surgery, offer resources dedicated to the promotion of surgery, and facilitate communication and interaction between students and practicing surgeons. So that's a little bit just very generally of kind of what we do. And then tonight we're joined by the general surgery residents. And we thank you all very much for dedicating your time to be on here. Jack is going to start with a couple questions for you guys, which you can kind of take a second to introduce yourself, and then we'll open it up to more questions from the group as a whole. So Jack, if you want to kick things off and start the ball rolling.
Well, good deal. Well, so I wanted to go around and have the residents introduce themselves. Tell us where you went to medical school, how you, real briefly, how you ended up over here at KU, and then what service you're on, and then accordingly, kind of what your day-to-day looks like. But before we jump into that, Dr. DePasco, do you want to say a couple words to all of our attendees here?
Sure. Thanks, Jack. Yeah, no, I'd be happy to. That's totally fine. So I first off, I'll start with a grand applause for the SSO team here. You guys should really be very, very appreciative of all the work that they've put in to put in some good content together and reach out to the residents and really give you an idea kind of a day in the life. And that's what our residents are going to bring to you tonight. Please think of this session as an open session. I don't want to speak out of turn, but I think it should be a kind of an informal. If a question comes up, just go ahead and run it out there. Don't forget to use the chat function, because that's really an important place to get kind of in medias res questions going and stream of thought type issues out there. So, and if I might be so bold, I might recommend, if the students in the room, as the membership of the group, if you wouldn't mind just putting on the chat feature, just type in what you think your interest is. If you're undecided, put undecided. If you have a mind for something, doesn't have to be elaborate, just say, I think I want a BA, and then fill in the blank. Might be nice for the residents to see that before they go ahead and go through all their kind of conversation. So, but that being said, I'll kind of fade out and just be listening in and be available if necessary. But this is you guys.
Excellent. Well, thanks, Dr. DePasco. Thanks for your help with getting all this going. So, Dr. Liebscher, I see you first on my screen. If you want to get us started here, like I said, just some of those questions, where you came from, how you end up over here at KU, and then what service you're on, what does a day in your life here look like?
Yeah, so I grew up in Colorado, went to medical school at Loyola Chicago, and actually kind of ended up at KU a little serendipitously. I got some cousins that live in town, and they asked if I would come visit, and I said, oh, sure, I'll apply to KU, try and get a trip out to Kansas out of the deal, and then came out here for my interview and loved it, and have been here ever since. I'm a PGY3. I just finished up on my surgical oncology rotation and just started CTS on Saturday, so today was my first real day on CTS. I'm the only resident on the service. There's a bunch of fellows that we work with most of the time. And today we did a couple EGDs for a couple people that had prior esophageal bursts, checking on how those were healing up. Dilated somebody with an esophageal stricture, and then did a right middle lobectomy for some lung cancer. So it's an exciting day.
All righty. Dr. Brungard?
Yeah, hey, I'm Joe Brungard. I'm a fourth year. My path is kind of a little bit different probably than most. I was born in Wichita and then went to Benedictine College for undergrad, and then med school. The first 2 years was here, and the second two, the clinical years, were in Wichita. And then out of Wichita, I matched to Savannah, Georgia at a program as kind of a hybrid program for 2 years. And then midway through the second year, a spot opened up here, and got the call and offer to come back, and jumped on that with wife and kid, and that's been great. So been here now a year and going into a year and a half. came off of surgical ICU, which was piggybacked into nights for us the past few months. And then this week have started general elective surgery, so Dr. Fran, Dr. Alley. I'm actually on clinical development, so kind of playing covering other people that are out. And one of our fives is out. She just had a kid, so covering general elective while she's out. We just did a hernia day, so inguinal hernia and ventral hernia and incisional hernia, component separation, knocked that out. So yeah, it's kind of our day. I don't know if there's any other questions in all that you'll wanted to hear.
Yeah, I think there will certainly be a couple others here as we get going, but we can go ahead and see Dr. Jabari.
Dr. Jabari.
Not getting your audio there, Java. I don't know if you can hear us or not. It's also quite a ominous. There you go. You can see your face now. Yeah, it's just a specter. You looked like you're in the witness protection program for a minute there. All right.
Let's see, Dr. Nix can go.
Hey guys, my name's Quinn. I'm one of the PGY2s. I'm from South Carolina originally. That's where I did a lot of my education and stuff at. I went to Clemson for undergrad and then University of South Carolina for medical school. I actually came out here.
I don't know where to sit. I've never been here, so I don't know if I should be somewhere else or am I in your way?
Are you one of the school volunteers?
So,
Yeah, first year.
Cool.
So you have everybody mute their mic, please.
Oh, I'm doing phlebotomy. Yeah. Okay.
There we go. All right.
Shout out to Josh. No worries. Yeah, so I went to University of South Carolina for medical school. I actually had a friend from medical school who was from around here originally, recommended me coming out and giving the program a try. So I did an away rotation out here as a fourth-year medical student. I really liked the experience. I liked the residents that I worked with, so I ranked pretty highly and matched here. I've really enjoyed it ever since I got here. I just got off of our transplant surgery service where we do all kidney, liver, and pancreas transplants. And then just started our breast rotation today. Did a couple mastectomies and some lumpectomies down to Indian Creek. So that's kind of where I'm at right now.
All right, thank you. And then Dr. Jabari, you see if your audio is working?
Can you guys hear me?
You sound great.
All right, great. Sorry, I was using my computer and it was acting weird. I don't know why. I'm Java. I'm one of the third years. So I was actually on surgical oncology with Sean. That's one of our busiest services. So we have a lot of residents who are on that service. And I just started my research rotation. So I don't have any super exciting operating stories for you guys. I basically going to catch up on my emails and kind of organize my schedule for this block. So I don't know if you guys know this or not, but we are required to do some research. This isn't not just like a KU requirement, but an ACGME requirement. So we have some dedicated research time during our third year. We get about 10 weeks to actually work on our projects to, get stuff published and so forth. So the way I end up at KU is I'm actually originally from Maryland. I went to undergrad on the East Coast, and then I went to med school at Creighton. And my clerkship director and just people at Creighton recommended that I apply to KU, and I did. And like Sean said, when I interviewed here, I really liked it. So that's kind of what you guys will find when you interview at places, whatever you decide to do. There's like a feel to places, and sometimes you can't even explain why, but you like them. And I've been really happy here so far. And can answer any questions you guys have, specific questions.
Alrighty, and then is Dr. Odell on yet? No, Tom said he was joining later.
Yeah, he said he might join us a little later, but it doesn't look like he's on yet.
All good. All right, Tom, well, do you want to go ahead and jump to some of these questions that we had kind of set up? And then obviously as other questions come up, just feel free to sit in the chat and let us know kind of what those questions are. But, I think a lot of students are wondering kind of, I guess, to start out with, what made you interested in surgery? How did you know you're interested in surgery? I guess, when did that kind of decision occur? And how did you overall develop that interest that you have?
I can go first. So I always knew that I wanted to do something procedural, like internal medicine rounds, especially like third year when I started to do clinical stuff. They were just like driving me insane because it was a lot of like talking and walking. And by the time we were like rounding on the patient, everything was pretty much irrelevant from like the day's labs and so forth. In general, I'm very much like, I'm not as much of like a process-oriented person. I'm more of like a result-oriented person. So like managing a chronic illness just didn't seem as satisfying to me as something that was like tangible and I could do and fix. And then I did like the creative and the technical aspect of surgery, which you don't really find in a lot of specialties. I did try to convince myself of doing other things, because you guys will find that if you are interested in surgery, there will be a lot of people out there who will try to convince you not to do it because they'll say it's hard and it's long hours and this and that. But I just always felt like at the end of the day, if I was trying to convince myself to do radiology or peds, do NICU, to do some procedures, anything like that, it just didn't feel right. And that's kind of like, that was kind of my sign that that's what I wanted to do. And I tried to rotate on a bunch of different surgical services to make sure that I kind of like the different, types of surgery. I did like colorectal surgery, I did like burn surgery, I did trauma, I did a couple other things. So just to make sure, I'm not just liking one operation or one surgeon. And I think that kind of really helped solidify my decision.
Any other residents want to weigh in on that kind of question about how you developed your interest?
I can weigh in. Aside from agreeing with pretty much everything that Java just said, what really sold the deal for me was when I couldn't figure out what I liked. I liked everything. I'd finish each rotation and say to myself, "Oh no, this is what I'm going to do with the rest of my life." And then I realized you get to do all that in general surgery. So you get to take care of all the medicine aspects of people. You get to manage their hypertension, manage their diabetes. When they get critically ill, you get to manage patients who are intubated and on pressors. And then you get to actually take them to the operating room and fix whatever the problem is. So like, I'm halfway through my residency right now, and aside from a few cardiac patients, I'm pretty much, you can throw any patient at me and I'll be able to keep them alive, at least until someone who knows how to fix the problem shows up. Then that feels pretty good once you're only being partway through residency.
We can move on to another question if you guys would like to. One of the questions we have is, what would you urge students who are interested in surgery to consider? For example, sacrifices needed to succeed in the career and the gratification of surgery, which you guys kind of already touched on that a little bit, but something that students wouldn't really realize without, I know that's a pretty general question, but I don't know, maybe misconceptions about surgery, the lifestyle, that kind of thing.
Yeah, I might suggest maybe breaking that up into small bites, in the sense that, like, I know all you guys mentioned that you what services you were on and kind of what you were doing in your day, but like literally, what does a day look like? Like, when does the alarm go off? When do you get to work? What are the duties that you have to go through in order to I'm sorry, guys, if I'm jumping ahead, but in the questions that you've got, but
no, that's a great question.
Just to kind of give, really, what does your life look like? I can think back to what mine did, but I don't even know what it looks like for you guys nowadays. Joe, tell me about your senior resident. What do you think?
Yeah, I think the really cool thing about general surgery now compared to the expectation, 30, 40 years ago, where a general surgeon would come out at a training and then be, working sun up to sundown, now is that there's something for everybody. There's something that you can go and get into somewhere that'll fit what you want to do. I think that's really cool. I think now, though, it's like gen elective. I'm up at 4 every day, no matter what. Like, I just get up and get going, and then we round, 6 a.m., 6:30, knock out. We only have a few patients. We got to knock that out. And then, 7:30, going to the ORs, pre-op patients. Like today, we're done at 3 something. That'll vary day to day. The KMOT just came off surgical ICU, so it's a little bit different. We work to make that more of a shift work. So 6 a.m. to essentially 7 p.m. for the day team, and 6 p.m. to 6:30 a.m. for the night team. And other programs are going to be different. The program I went to in Savannah, that was, the night team was there for basically damage control, and you came in and you were managing everybody start to finish, kind of sign out what you needed to do, and then that was it. So I don't know if maybe Quinn has his thoughts on what rotation he's on now.
Sorry, I was answering a page. Or what, you just want to know, like, basic what day in the life is like what every rotation
Yeah,
is?
maybe start with day in the life type stuff.
Yeah, sure. So my daily routine totally just changed. When I was on our transplant service, it's a pretty busy service that we have. As the second year, you're responsible for covering all the transplants, whether they be overnight, during the day, whenever those are. So that's a pretty busy service. That typically would consist of getting there around 5:15, 5:30 every morning, rounding around 6 o'clock or so, and then just kind of going along as the day goes. Sometimes it's extremely busy as you have a lot of transplants to do. Other times it can be a little bit slower pace and you have a chance to kind of catch your breath. And there's a lot of call involved with that too. So I guess last week, when I was on the transplant rotation, it was at least 2 or 3 nights each day that I was either operating into the night or in the middle of the night. So it's a pretty busy service. I just switched over today to our breast service, which is a little bit more scheduled. So today it was a little nice. I got to sleep in a little bit, so I wasn't upset about that. But we started today down at Indian Creek and then got to do a little bit more routine stuff, which was nice. So it definitely is very routine dependent, service dependent. But I think that it's pretty consistently, like, you start early in the morning and then just kind of every day is a little bit different.
So I think a lot of people, myself probably included, have a thought of these 24-hour shifts, things like that. And I know that you talked about shift work and like the SICU, where you're working either mornings or evenings, but for the other services other than surgical ICU, is there times when you realistically will expect to be there in the middle of the night, or is that just kind of with your example with transplant, if that's when the transplant needs to occur, things like that?
Yeah, I'll answer that one just because it was what I was talking about. It's pretty unusual given the system that we have set up with a night float team. For the most part, everything that happens at night is covered by the night team. There are certain things, if you're the upper level on our vascular service, or if you're the mid-level on our transplant service, you'll do those cases in the middle of the night. But we do have a pretty nice setup to where taking pages, that kind of stuff, typically goes to the night team. So not something that you have to worry about too much.
And the night team being those that are on the surgical ICU service.
Correct. Yeah. And so what we have is a first through a fourth year who cover all the services at night. So it's the intern answering pages, second year and third year typically running the ICU, and then our upper level, our fourth year is typically doing cases that go on at night.
So just to kind of give you guys like an idea of night float versus call, because this is something I did not really understand well until I started applying for residency. There's two different systems in terms of how the patients in the hospital, new consults, everything gets covered. I don't know how many of you are like M3s, M4s, or M1s, or M2s, and like who's applying, who's not. But just to kind of break things down, there are a couple of things to think about when you apply for residency. One, are you going to be at a level 1 trauma center? If you're going to be at a level 1 trauma center, most likely you'll have some residents in-house who are going to be covering traumas. Even if you're at a level 2 trauma center, you're going to do that. But it's a little bit different if you're not at a level 1. You will have, there are usually 2 different systems of covering cases and patients and so forth. There's a night float system. That means they are dedicated residents. It used to be 3 for us when I first started, but now it's 4 because of the high volume of patients that we have. Those residents, they stay home during the day and sleep. They come to work at night. They come to work from 6 p.m. to 6 a.m. They cover pretty much all of our services with the exception of breast surgery and pediatric surgery. And that's because one is operating from a different campus and one is not high volume. And they also don't cover the ICC campus because they're not there. So they basically cover every single service at KU that's surgical. So they see all the consults, they take care of all the patients, and the senior resident on that service does all of the emergency surgeries, unless the emergency surgery is on like vascular or colorectal or surgical oncology or transplant. At that point, the chief resident on that service gets called into surgeries, but it's not very common for those services to have in the middle of the night surgeries, except for vascular it is. So if you're a vascular chief, you do a lot. You do operate a lot. Or the transplant resident who's a 2. If there are some programs that don't have the system, so let's say you're on colorectal surgery, you keep your pager throughout the night. If something comes up, you get called about it. And usually there is 1 person or 2 people in-house that do cover stuff that comes in. And that person who's in-house, they're usually like on call every like 3 nights, every 4 nights. And that's why they call it like Q2 call, Q3 call, Q4 call. And that person gets like the next 24 hours off. So that's like something to really think about when you're applying to residency. Personally, the night flow system, I think it's really good because you go home, you sleep, you have like a normal schedule. When you're on nights, you have like a normal schedule because you're on nights, and you don't have to flip-flop so much. In terms of like a day in the life, like Joe wakes up at 4 every morning. I wake up the latest possible because I've never been a morning person. So Dr. DePasco asked like, what is like a lifestyle change? For me personally is like waking up super early, and the fact that I now go to bed at 9:30, because before residency, I thought people who did that were just really weird, but now I'm one of those people. So you wake up whenever you have to, you come in, you try to check your patients, you make sure, just like you would as a med student, you make sure they're okay, you make sure you order anything that you need to beforehand. If you do, then you go see them. Then you come back and put in more orders. You call the attendings, you talk to them about it. Then you go pre-op your patients to the operating room. Then you operate. After operating, you round again on patients, make sure everything is tidied up. In between operating, you see consults or whatever comes in. And typically we check out around 6 to 6:30 p.m., but most of us stay and finish all of our cases before doing that. If you have clinic, then you just go to clinic and during the day. And most of us go to clinic at least a half day a week. That's a requirement, sometimes even more.
Yeah, going off of Dr. DePasco's, what did you not expect in residency? Like I would ask, what's one of the most challenging things about residency, whether it's, I know you guys have talked about the hours, whether it's the surgery itself, or if, you guys don't like the clinic side of it. What's one of the more challenging things about your residencies?
I think the most challenging thing about surgical residency is that it is your number 1 priority. Everything else in your life, whether you like it or not, does kind of, just evolve around surgical residency, because you spend so much time on it, and it's only a few short years, and you have to learn so much. So it's like a really important time in your life. So, you know, it's really important to like surround yourself with people who really are able to be there for you when you do something like that, whether it's a partner or it's family or friends or whatever. It's really important to have a good support system, because, you know, it's hard. You spend so many hours doing it. In terms of having a good work-life balance, I think somebody asked that in the chat. I think the good thing about where medicine is going right now is that, you know, I feel like 10 years ago, even like 5 years ago, there was this sense of pride about being a workaholic, which you still see in medicine, that people just, you know, want to make it a point to let you know that they work really hard and they never sleep and all this stuff. But I think a little bit of that is changing towards the idea of having balance in life. And now we're starting to look at people who have work-life balance as people that we want to be like, not the people that never see their kids or are not like, don't have any friends and just work. So I think that culture is helping people accept like, you know, taking a little bit of time off to relax, or advocate for people to do have those, that balance. So, but I'm not going to lie, like the balance will still tilt towards work, at least during residency. I think Joe made a good point. Like general surgery is changing a little bit. So you can, you know, go into specialties from general surgery where you will have more of that life versus work balance. But if you want to be all work, then you can also have specialties, subspecialties that do that. But in residency, it's going to be a little bit harder to do it. It's not impossible. The way I think about it is I force myself to do things. I force myself to go out, and I force myself to hang out with my fiance and my friends, even if I am exhausted. Like I'll go out with friends, or I'll go to a party, and sometimes I'll take a nap for 30 minutes while I'm there, and then I'll continue to participate in everything that's going on. And they've just accepted that about me. So.
Also like to point out that of all the people that are on this call, Dr. Jabari is at home, Dr. Nix is at home, and it looks like Dr. Pasco, correct me if I'm wrong, but you're at home, I'm at home, and we've all been at home since 5 o'clock. So it's a little bit service dependent. Like when Dr. Nix was on transplant service, there was no way he would be home at 5:30, and he'd probably still be looking to be in the hospital for another 4 hours. But now that he's on breast surgery, if he's home later than 2:30 or 3, that's a late day for him. And so that kind of changes, and you got to kind of take advantage of those times when those times come. So like when I was on my breast service, I spent a lot of time with my wife and hung out and spent much quality time with her as I could, because I knew that the next month when I rolled onto the transplant service, I wasn't going to get to do that as much. And it's taken a lot of understanding on her part to know that there are times when I'll be around and times when I won't be around. And I've just been very fortunate to have somebody that understands that. It also definitely kind of is up to you as to like how efficient can you be. So like I live 30 minutes from the hospital, and I listen to surgery podcasts on the way to and from work. And you can get the Amazon Kindle app to read you textbooks as you're going to and from work. So I spend an hour every day studying just on my commute back and forth to work. So by the time I get home, I can be done, and I can just hang out and have dinner and sit on the couch, and I don't have to worry about looking up for tomorrow's cases because I've already done all that. And so if you're focused and doing it, you can find time to do other things that you like. Like when we get off the phone call here, I'm gonna go for a 15-mile bike ride just because I got nothing to do for the rest of the day. So.
Can I add in something as well as far as lifestyle goes?
Please do.
You know, yeah, I mean, I've got the one unique comment in the room, and this is actually really important for the residents to hear as well. I think they have an idea, but it's nice to hear this, confirmed. The fact is, let's face it, when you're a resident in surgery, you don't have your own schedule for the most part. I mean, certainly when you're in the hospital, I mean, at every given second of any given day, you could get a page and all of a sudden you're doing something that you weren't doing 5 minutes ago. And it's like, that's just life. And when you're off and you're at home, things are a lot easier, obviously. And it's nice that there's some flexibilities to spend time at home and so forth, more than there used to be. But it is, residency's tough from that standpoint. Now, that gets a ton better when you get out. When you're done with your residency, with your fellowship, and you're in attending, whether you're in a community setting or in a university setting, you just have a tremendous amount of flexibility. I mean, to a certain extent, no one really tells you what to do anymore. In the sense that if I have a day, if it's the first day of school for my kids and I really want to be there, I can just schedule off that day and I'm not there that day, and no one's ever going to be in trouble for that. Now, if I do that a lot, eventually my chair or my chief or CMO is going to say, hey, you're not making any money because you're taking a lot of days off. So you will have consequences eventually. But again, you have the flexibility to do it within reason. And so, lifestyle really goes up exponentially once you're out of training. And that's not a surprise to anybody. But I will say one thing, and Java said it, and it is important, and it is really an important thing to realize about surgery. No matter where you are in the grand scheme of things, surgery, for better or worse, is the priority. It's not something you can just walk away from. Right now I'm sitting here in my house, the kids are getting ready for dinner and all that kind of stuff. But if I get a call that one of my patients is going downhill fast, I'm out of here. And even more acutely, problematic is, let's say I'm in the operating room on just a regular workday, and I'm hands in working. If something bad happens with one of my kids or my wife or something, I can't just walk out of that room. I mean, I have to find someone that can take care of this living body who has already willed themselves to me for the time being. And so it's, when it comes down to brass tacks, that's reality, and you can't escape that. There are ways to manage it. You can either do shifts, or you can kind of do certain types of disciplines of surgery where the hazard is lower, but it's never a zero sum game. You always know that surgery is a priority that you can't walk away from. And forgive me for coining a term from a very androcentric past, but the phrase that used to be used here is that surgery is a cruel mistress. And what that meant is, like, she treats you badly, and a lot of bad harm comes from it, but you keep going back. You can't stop yourself. And again, it's androcentric, but it does have a point to it, in the sense that, yeah, it's hard to miss that birthday party, or it's hard to miss that movie that you wanted to go to or whatever, but you don't have a choice. And matter of fact, even when you're there, you're still having fun. When you get to do that case and things go well and you save your patient or whatever, there's a buzz there that you can't describe. It is, and I know all the residents are shaking their head because they've felt it. And it's I not only do I think that it's important, but it's existential to being a surgeon. It's part of the thrill of being a surgeon, actually. So I'll butt out now.
No, that's a really good point. And Dr. Pasco had sent me a question earlier about, what is that buzz when you realize, hey, this is not easy by any means. This really is a difficult field, and with all sacrifice and everything else. But what is that moment of, wow, I really am glad to be here, and I'm really fortunate and happy I'm a surgeon. Kind of makes the years of training, and you hear about everybody in medicine. I sacrificed my 20s, what have you. What is that moment?
Yeah, and I can use my own example and then I'll let the residents each think of their own last moment, because these happen all the time. So residents, just think about the last time that you said to yourself, man, I am so glad to be a surgeon, or I'm so glad to be doing this, I'm so lucky, etc. I can tell you, when I was a resident, this wasn't the last time, this was one of the first times I really realized it. It's when I was a resident and I would walk out of a call that would be 30 hours long or whatever, and I was dead. I was exhausted. I was not feeling good. But that sunlight would hit my face. I'd be walking out to the car and I'd kind of do a little bit of a review. And I thought to myself, hey, you know what? I didn't hurt anybody last night. We saved some people. Everything went really well. I didn't get in trouble. I feel like $1,000,000. And I still remember that zing of how good that felt, even after the immediacy of the pain of going through a 24-hour plus call. It still felt that good. So residents, what are those moments? What was the last moment like that you had?
Well, I'll go if no one else has, if everyone's still thinking. I did, so on nights in SICU, you do trauma. We did 4 or 5 ED thoracotomies in that time. And the last couple we had, we got people to the OR. And the very last one I did, we knew she was coming in. She's down. She was a traumatic gunshot arrest. So we had time to prep. Everything went super smooth. The whole team was just in sync. Got her to the OR right away. Got her back for a while. And, even though ultimately that patient died, everyone was working to do absolutely everything they could. And you could just look around and be like, we did it right this time. And that's, that's something to be pretty proud of, I think.
That's a huge feeling. I totally agree. Sean?
Mine's not nearly as dramatic as that, but last week I was working with one of our surgical oncologists, Dr. Al Caspools, and I had worked with him the week prior as well, and we'd done a couple right hemicolectomies that week, and so we were doing another one this last Tuesday, and he basically, with him and my chief, basically walked me through the whole thing, and I got to do pretty much the entire case, start to finish, and to realize as I was walking out of that door, man, I might have been able to do that one, if not all of it myself, the vast majority of it myself. It was a really cool feeling, considering that at the start of last week, I had done one of them before, and aside from getting into the abdomen, that had been my first step, and then I would have kind of been like, okay, somebody needs to tell me what to do next. It's like, I might actually be learning something. This feels kind of sweet.
I can go next on this. Mine actually comes outside of the OR. So we were recently, just came off our transplant service. We were seeing patients post-operatively just as a follow-up. And just whenever you see someone who you've operated on and you've made a big difference in their life, I think that's actually when I get the most wow, I really made a difference. I did something really cool. I think everyone who gets in the operating room, they think, operating itself is awesome. And I think that you have to be in there, and to be good and to want to do surgery, you have to like being in the operating room. But for me, most of those, this is what I need to be doing, this is why I'm here, actually comes in the clinic. I think a lot of us are oh, we hate going to clinic. It's not as fun as operating. But when you see that transplant patient, 3 or 4 weeks out, and they've been on dialysis for 6 years, and you suddenly change their life, and they can be a functioning human again. For me, that's the biggest, wow, I've really done something here. I've really given this person their life back, essentially. So I think for me, it's seeing those patients post-operatively, seeing the difference that you've made. That's when I'm like, oh yeah, this is really cool. That's when I knew that I wanted to do it.
I kind of have a similar story as Sean, but last week I did a bunch of LARs, and we got called into a different surgeon's room, a gyne room, and they needed help, and I basically was able to I knew exactly what I was doing, and it was no more do this first, do this next, and there was a good flow between me and the surgeon I was operating with, and we literally finished it in less than 20 minutes. Now they had the good exposure for us, but still. And it just felt good to just be okay, I don't need to be walk through everything, and I can come in and help another surgeon and walk out within 20 minutes and completely change this person's life.
So I have to ask, how common is something like that, where you are called into, and you said you went into a gyno OR, is that pretty common throughout the day, where you're called into different operating rooms? Or when I was thinking call, I was mainly thinking ER, but that's kind of helpful to understand that difference.
It just depends on what service you are on. So, for instance, like if there's a trauma that comes in and there's like a thoracic injury, so the CTS guys will get called in. Or if there's a vascular injury, the vascular surgeon might get called in. The colorectal surgery team and the gyn-onc team work very closely together because a lot of the gyn cancers end up being stuck to colon, rectum, so forth, and sometimes they'll need help. I wouldn't say it's like super common on every service for that sort of thing to happen, but on some services it's more common than others. Like on, I'd say colorectal, we have at least like 1 or 2 cases either that is combined with gynecology, gyn-onc, or that we get called into their cases if they weren't expecting to have like bowel involvement, but they did. But usually they're pretty good at kind of looking at CTs and so forth and getting us involved beforehand. But sometimes it does happen that they don't.
Thank you. I wanted to highlight a question in the chat asked specifically from Tevin. So was it initially hard to change sleep cycles to the night shift? Were you able to learn how to be an adaptive sleeper? And I would kind of add on to that, I know that Dr. Jabbar, you had mentioned having to become a morning person or maybe you wouldn't say that you've become a morning person, but you are by necessity a morning person. But other adaptations like that, such as being on your feet all day, what's been your experience like with those things?
I can speak for the sleeping thing. It seems to me that talking to other residents and I know this is the case for me, it takes me about a week to get completely switched over onto a night schedule. Now, that doesn't mean that like there's always so much going on in the hospital that there's like you don't really I don't know. For me, I don't really ever feel like tired when there's something going on. It's when you've got everything wrapped up for the day or I guess the night, and like it's kind of like 2 or 3 o'clock in the morning, and the patients have all kind of fallen asleep. So their pages have kind of slowed down. People have stopped coming to the emergency room for a little bit. There's like an hour or 2 in there where the first week or so it gets a little hard to stay awake. But then as soon as the trauma pager goes off, your heart rate goes up, and it's not hard to stay awake and focus. And sleeping, it takes a little bit of time to get yourself switched over, but what ends up happening is you go home and you fall asleep right away when you get home at 7:30 or 8, and then you wake up at noon because your body's like, oh, it's the middle of the day, I'm supposed to be awake. And that takes all of about 3 or 4 days to work itself out, and then you're good. And then switching back from nights to days is even easier than that. Jack, to your question, is like, are there other scheduling things that get hard to get used to? I was like Java. I was like, well, I'm never gonna be that person that goes to bed at 9 o'clock. That's just lame. Like, I'll stay up later and it'll be fine. And that gets beaten out of you pretty quick. You get home at 9 or at 7:30 or 8 or so, and all you want to do is eat dinner. And the number of pictures my wife has of me sleeping on the couch is just unbelievable. Like, I'd say 3 or 4 nights a week at 8:30, and I've fallen asleep on the couch with my dog sleeping next to me. I don't know how Joe does it with children and having to take care of other small beings once he gets home. At least by the time I get home, I have no one else to be responsible for other than myself. But
can I mention one thing about lifestyle as well? And again, I don't look at this negatively, and I'm a real grown up now. I think I'm 40 years old. I got 4 kids. I've been in practice for almost a decade. Yeah, I'm not much of a night owl. I can do it if the party's cooking and I'm having a good time and all, but on most weeknights, so much so that even if I have like a drink, because and I don't really drink all that often, but if I just want a glass of bourbon or something, boy, if I have that, you can count on me going to sleep in about an hour. I'm gone. So I tend just not to have that drink, because then I don't get to talk to my wife, and she's like, "You fell asleep at 9 o'clock again," and all that kind of stuff. So she doesn't sound like that at all. It's very reasonable that she wants to talk to me at night because I'm working all day long. But yeah, that is a lifestyle change. I mean, yet I'll wake up at 5 a.m. without an alarm clock, just because I've been doing it for so many years. That's just the way I'm wired now. So you do kind of shift and adapt quite a bit. over the residency for sure, and it lasts, by the way.
All right, we got another question in the chat. I think it's a really good question from Josh. It says, how long in residency or into residency did it take you to get to the point of not memorizing procedures and operations step by step, and being able to do them with a good flow?
I'll let you know when I get there.
Yeah, say the same thing. I mean, it depends on the operation. Like, I think by most of us can, explain like an appendectomy or a cholecystectomy or something like that easily by like second year or something. But yeah, like if I'm doing a total gastrectomy, I'm going to still look up every single step of the procedure for the case. Because it's like, there's some nuances like what sort of suture you use for this, what do you use for that, and everybody's the attendings are a little bit different, so you want to make sure like when you're operating with someone what they like, because not every procedure is like super standard and done the same exact way. But there are certain procedures that you're going to be more comfortable doing and how to do, and there are certain ones that you're going to have to look up even as you're like a little bit older. I think the other thing is like, of course, if you do the same procedure over and over again within like a week or two, it's going to be a little bit easier for you. And then if you don't do it for like 3 or 4 months because you've been on a different rotation, or 8 months, when you're going to do it again, you have to look it up a little bit more. So.
And I don't know if everybody's seen the chat, but Dr. DePasca is saying that's why residency is 5 years long. So
amongst other reasons, but that's the biggest one, honestly, is what I've felt. And Joe might comment, as he's gotten pretty far in all this game so far. I mean, there's just such a maturation process of truly getting confident. And we're focusing a lot on the operating rooms, and this is good advice also for the residents. They've probably heard this before, but not only does residency take 5 years, but then as soon as you graduate, all of your attendings and the old guys, they all say, yeah, it'll take 5 years till you feel comfortable. And I hate to say it, but it is entirely true. I mean, you're doing the work, you're doing the cases, things are going fine, but inside you're like screaming half the day, like, oh my God, did I do a good job? Did I do a good job? And then 5 years out, you're like, yes, no problem. I can handle this. And you don't stop getting worried as much. You've seen it, you've been there, you've done it, and you've proven to yourself enough times that everything's going to be fine. So that 5-year thing is very real.
Yeah, I think one of my mentors once said, just kind of get out of the mentality that you're done, like with training or your education. It just evolves and changes over time. That once you get out of that, 5 years in a general surgery residency is not a big deal. 5 plus, 3 of a fellowship or whatever, it's less of a big deal. And you're thinking like long term, you're thinking in terms of your entire career. How does this play out, and how does this affect my overall education, stuff like that.
I mean, the other thing to think about is, like we have attendings who do laparoscopic, robotic surgery, all these things that they never ever saw in residency because it wasn't a big thing then. So there's always going to be something new. So even if you feel comfortable doing, whatever procedures you learn in residency, one, you're not going to see everything you're ever going to do in residency, like no matter where you go. And two, there's always going to be something new. So you always have to be like Joe said, it's like ongoing training, or like a lifelong learner. And I think that's like that in medicine in general now, but it just, you have the technical aspect to it added in surgery versus just the knowledge.
One thing I kind of wanted to ask about, without getting too far in the weeds, is I feel like a lot of people don't understand the specialization process that goes, after the general surgery residency. So if someone wanted to speak on that and what avenues you can go into, and if any of you have a particular one that you're interested in, I think that would be interesting to hear about.
So after a 5-year general surgery program residency, you can do, and anybody chime in if I'm missing anything here, trauma critical care, acute care, which is 1 year of critical care fellowship, possibly another year of acute care surgery bundled into that, but only 1 year is required to be critical care certified. Vascular, which is 2 years, pediatric surgery, which is 2 years, cardiothoracic, which is 2 or 3 years, plastic surgery, which is 3 years. Then other things like bariatric, it's its own fellowship, or minimally invasive surgery, it's its own dedicated time, but there are no board certifications for it. It's more of a certificate that you've completed that time. Breast surgery you can do, that's a year or 2. Anything else I'm missing there? Dr. Pasco's listed all that. Great. And transition to practice, that's a great one too. Surgeonc, of course, I missed that one. Transition to practice is a good one to bring up, because it's, a 6th year of general surgery where you're working more independently, maybe in a private practice setting. The times I've seen it, it's essentially a private practice that has the spot. I'm not sure what the pay is or the agreements are, but they help you work more independently before you fully go into practice. That's the gist of it.
Okay, and then we're kind of noticing that we're coming up on 6 o'clock here. So this is the last call for any other questions that anyone wants to ask. I know Mitch Kerr has a question in the chat, and that might be a good one to wrap it up on, since it's kind of a closing thoughts sort of thing. But does anyone else have any other questions before we end with that?
And if you're furiously typing so that we can see it on time, you just go ahead and unmute yourself and ask if you have it. All righty.
Okay, so I think if every resident would like to go through and just kind of mention one thing that you'd tell your past self prior to applying to general surgery residency, that might be a good kind of closing thought.
And I would just add one thing, sorry to get in the way, but that I think, I obviously see some M2s, see a couple M1s. There might even be a couple phase 2 students in here, but just generally speaking, we're open to hear any advice. And I also think Dr. DePasco could add some good insight here as well.
I'll let the residents go first. So what would med student Java, med student Quinn tell each other? What would you guys say to yourselves looking back in the mirror?
I can go first on this one. I think the big thing that I noticed, or at least that I definitely would tell myself afterwards, is that the workday doesn't end at 6:30. Just like Sean was saying, like, even though he leaves, he's done for the day, he's out of the hospital, he's listening to podcasts, he's reviewing for cases, he's reading about what he's doing the next day. I would say I spent the first maybe 3 to 6 months of residency just kind of staying afloat and keeping my head above water, figuring out what was going on. Once I really, I guess, I kind of rededicated myself, started reading more in the evenings when I got home. I'm spending my weekends like reviewing for things. I noticed, at least for me, suddenly things just started clicking more. I understood what was happening better. Once you kind of really delve in and realize that residency is just as much outside of the hospital as it is inside the hospital, I noticed a big difference in what I was able to do, what I was able to help the team with. So that was the biggest thing that I don't think I really realized ahead of time, is that it's not just a 6 to 6 job. It's a 24/7 job. So for me, that was the biggest difference that I would, I guess, tell my prior self before I started.
I think I would make sure that myself understood that hard work is going to get you really far. General surgery is a residency where you have, not only do you have to have a few brain cells to put together, but you need to be able to put your nose to the grindstone and put your head down and get the work done when it comes through, and be really self-motivated to do that, because unlike in other specialties, you roll in as an intern and your chief's going to go to the operating room and spend all day in the operating room, and it's going to be your job to make sure that all the plans you talked about between 6 and 7:30 get executed over the course of the day, and you handle all new consults and get all those taken care of. And if you are someone that's going to sit around and wait for someone to give you direction, it everything's just going to go off the rails and the work's just going to keep piling up. And so if that's not something that appeals to you, it's going to make your time in a general surgery residency really difficult. And so I would tell myself, get ready for that, because that's what's going to take.
Oh, I have a lot of things. Okay. The first thing is, I would probably just tell myself to relax more. 2 is that reputations are built early on, and that's really important. I think that's something people miss, and unfortunately, if you build a bad reputation early on, it's hard to get rid of it. And 3 is that if you do work hard, like Sean said, you will get recognized. And 4, and I think at least for me, that was the most important thing, was I mentioned this earlier, was the importance of having supportive people in your life. Because most of us probably work hard and all that stuff, but you can't do this alone. At least I can't. I don't know, maybe there's some other people who are super independent, but I'm kind of needy sometimes. So it's nice to have those people in your life who can help you get through it, because you do need it. But I think those are the main things. But if anybody wants to send me an email, I can send you like a list.
I agree with all that. I don't think I have anything else that comes to mind right off the bat.
I can say that mine would be very clearly, you're going to learn a lot about time management, buddy, because that was not something I was very good at. And, people talked about it earlier, but just even thinking about things like rounds and stuff, I'm just the kind of person that tends to just kind of lean into an experience and just savor it and enjoy it and kind of milk it all for its worth. And many times that's not rational or possible in surgery. It's very fast paced. There's a lot of work to do. And even though you can kind of create, work flows that gets everything done, there can still be consequences in that your day is just longer, and then you're not home with your family and home with your friends and all that kind of stuff. And it doesn't have to be that way. So if you kind of beat yourself into realizing, look, I know there's a way I like to do things and it's a little slower, but there's a better way to do things a little faster that works just as well. And I have to flex into that comfort zone and make it happen. So that was just one of the lessons that I certainly would like to have learned earlier than I did.
Awesome. That's all very good advice. Well, I just want to say thank you to all our panelists, to Dr. DePasco. Jack, did you have anything else before we convened?
No, I'll just say thank you. And I think, just as far as students that have questions after this, don't want to speak for the residents, but I'm sure that folks will be willing to answer other questions that come up. So just email Tom or I, or kind of however you heard about this, and let us know if there's something else that's unanswered. We can pass that along and get you an answer. So I think we, as the Student Surgery Organization, just like Tom said, we want to be helpful in trying to, as students have interest that maybe isn't covered in a lecture or covered in a CBCL or whatever, we'd like to be helpful in getting that to you. So let us know how we can be of assistance.
Thanks again, everybody.
Yeah, I'd like to just point out real quick to you guys. I think everybody's aware that Dr. DePasco is leaving. And so one of the best links between you all as students and us as residents is now unfortunately not going to be with us anymore. That sounds kind of morbid. But all of us are very open to hearing from you. So just if you have questions, feel free to email them directly to us. I think all of our emails were in the email that went out that Tom and Jack sent. we're not as scary as everybody tries to make us out to be. So just please send us an email, and we're always happy to meet and chat and help with whatever it is, whether it's fourth years who are looking to write their personal statements or whatever. I had some great help from the residents where I was at med school. Happy to help anybody that wants to extra set eyes on that. To first years deciding whether they want to take their time and do a little extra, spend some time in just operating or anything like that. Just send us an email. I'm happy to help you out.
And though I'm not dying, it is important to mention that, as Sean said, that link, each one of these residents has my cell phone number and my contact, which is going with me. So if you guys ever need to get a hold of me, they can be that link between you and I as well. So it's been a pleasure.
We will miss you here at KU, Dr. DePasca. Thanks for all your service, patients and students and faculty, everybody else alike. So
yeah, thank you.
All right, everybody. Well, have a great rest of your week, and we'll see you at the next meeting here. Should be hopefully something in October, and we'll see you then.
Thank you, everyone.